My name is Dr. Martin Dietrich. I'm a medical oncologist in Orlando, Florida. COVID-19 in cancer care has really changed the way how we're doing things. We've moved to televisits, we moved to spacing out visits, planning ahead more than we typically would do. It's less protocol driven and more individualized. This is true for the in-person contact visits as well as for the scans and other surveillance tests that we're doing. It's much more challenging now with newer patients to decide about initiation of therapies. Obviously have concern about activation of virus infections that may be running asymptomatically. There's a concern about testing availability as well as the false negative rate of testing. So clearly a new age in oncology and a completely new dimension of challenges in terms of the infectious aspect of cancer treatment. The impact of COVID-19 on medical practice was significant. I believe my clinic has never looked the way it is looking now. And I don't think it will be looking like it was before COVID-19 was a clinical problem. I think we've had some very good success in follow-ups with patients with telemedicine. Obviously, we'll have to develop techniques and technologies to make these communication channels more interactive, to possibly involve them in a clinical exam scenario in remote locations. I believe telemedicine has been working on this for a long time. Obviously, those are the standard follow-up visits where technology is enhancing them, and I believe COVID-19 is actually a chance of introducing these technologies as a modern way of delivering medical care. I think it's much more difficult for patients that are newly diagnosed or on active treatment. Most patients obviously need to be treated with extra care. We need to make sure that we screen these patients for clinical symptoms, but eventually when testing capability becomes available, also for asymptomatic carriers, to make sure that we drop the spread in the community and also avoid the concern about coexisting conditions that may be mutually aggravating each other. A particular concern is using chemotherapy in setting of a COVID infection and aggravating a viral exacerbation. I believe one of the most clinically challenging scenarios is the recognition of side effects. I believe what we've learned is that COVID-19 really is a polytropic virus that can affect multiple organ systems, can affect the lungs in particular, but has shown manifestation in the nervous system, in the skin, in the muscle, in the brain. They're the first cases of leptomeningeal involvement, and differentiating the viral impact from the contribution of cancer and its therapies is going to be particularly challenging. I believe we'll learn a lot about this in the next 6 months. But for the time being, obviously we'll have to be extra cautious and use proper clinical judgment and a very honest level of discussion with our patients to make the right decisions. We'll make wrong decisions. I believe this is inevitable when you're starting to learn about a new set of illnesses. I believe proceeding with caution as much as possible, I believe, is very important. Try to space out therapies if it's possible, shorten therapies if it's possible, and if available, switch from from intravenous oncolytics to oral oncolytics as a way of minimizing the physical contact with the clinic as a potential source of viral infection. Anxiety is an issue that has been penetrating cancer care all along. Obviously, it's a high stress environment. It's a new diagnosis. Frequently, the concern about expectations for quality of life, treatment complications, and life expectancy make this already a high pressure, high stress environment. COVID-19 has given this an additional aggravation. Obviously, we hear a lot about the ongoing clinical scenarios in the different regions, obviously some more affected than others. Obviously, I see this in my schedule. A lot of patients are staying away from the clinic, even if their clinical visit would be advisable, for concern about the COVID-19 infections. I believe the only way to address this is to have an honest level of communication, an honest level of risk assessment. I believe as we learn more and protective equipment becomes more and more available, I believe we'll be able to alleviate some of these concerns. But in the current scenario, a lot of the decisions that we're making are clearly not based on evidence, but are based on concerns and fears that have been the result of the data that has been obtained, particularly in New York, obviously, but in other centers around the world, centers of disease around the world as well. I believe we'll have a dramatic challenge to balance these two disease centers, because in a certain way you sit between a rock and a hard place. You definitely want to provide the same level of cancer care and the same level of evidence-based treatment for cancer that we delivered before the COVID-19 crisis. We also want to make sure we pay attention to the physical and psychosocial health of a patient. That includes obviously addressing the fear of COVID-19. One of my recommendations is to follow the data there as closely as possible and not necessarily be led on by many of the information channels that we're exposed to, and sharing this with patients. Unfortunately, when you're in a nationwide a situation of a lockdown and patients are consuming a lot of information from the news media and other scenarios, this is time that's additionally very unsettling. So it is a particularly challenge, and I believe we have to spend a lot of time and energy in addressing these concerns, being available for communication, being available for questions, and as I said, learning as we go along and making sure that the cancer care is delivered as safely as possible, and that the understanding prevails that even though this is a challenging environment, the fundamentals of cancer care are going to be delivered to the patient in the same way like we did before the crisis. Well, patient education, I believe, is one of the most important aspects of this. I believe most of the organization, whether it's the American College of Physicians, the American Medical Association, ASCO, others, they have provided patient-centric resources of information. They have been working diligently in summarizing the evidence that we have and formulating evidence-based recommendations. I believe those are great resources for patients to find information, as well as find some reassurance in what things have been made available, what is already understood, and what testing and treatment capabilities are available. We'll obviously have to make sure that we balance this very carefully with the other available sources of information. We have to make sure that we have a evidence-based angle to everything that we're doing. Unfortunately, this is one of the major concerns in this current crisis, is that we're so desperate for a hope and desperate for solutions that we're clinging on to every straw that is available. Unfortunately, many of them do not lack the current and necessary level of evidence support to actually be recommended. I think that's important for patients to understand, and the advocacy groups are the most important venues in reaching those patients in their homes, through social media, through basically the big noise of information influx that patients are exposed to right now. So working together closely through the different organizations in oncology is going to be key to make sure that patients are actually going to be able to master this crisis in good psychosocial health. Well, my specialty is thoracic oncology, and I have a number of treatment modalities that I'm treating side by side in patients. I believe we have made major progress in terms of treatment with both targeted and immunotherapies. Obviously, one of the biggest concerns for both modalities is the concern about autoimmune pneumonitis. It's very difficult to distinguish them physiologically and radiographically from the impact that COVID-19 may have. And it's very difficult to make a decision about continuation and initiation of treatment in the setting of a lung abnormality. We're trying to understand more what the COVID-19 induced lung injury looks like, and kind of get a variety of opinions here from an ARDS picture with elevated resistance and decreased compliance in the airway to more pulmonary edema kind of situation. And I think there may be multiple ways of presenting this. And until we have a clear understanding, we really have to work around the challenges of diagnostics and differential diagnosis of these different presentations, which will include withholding therapy if appropriate, and delaying or spacing them out as necessary until this crisis is abated.